In today's video, we will be talking about strain imaging by echocardiography. I am Dr. Praveen. I am Assistant Professor at UNMICRC Institute of Cardiology and Research Center. So strain is equivalent to deformation, which is deformation when there is a stress. So the echocardiographic strain is a deformation imaging. It quantifies the regional myocardial function. In strain, when the sarcomere, which shortens in a unidirectional way, it results in multidirectional change in size and shape of the tissue. The shear strain is changing the angle between the two line segments, and in a myocardial fiber, there is myocardial wall, there is 3D object. The myocardial wall is more like a 3D object. The strain is along 3 planes, and there is also rotation. So the myocardial fibers are oriented in different ways at different levels. The endocardial fibers run main from the apex to the base. Then the mid myocardial fibers run around, and the epicardial fibers are oblique, which gives rise to different types of strains: a longitudinal strain, radial shortening, and also circumferential shortening. So the types of strains are mainly of 4 principal types, which is longitudinal, radial, circumferential, and also rotational component. Then there is also strain percentage, that is, there is a fractional change in length of a myocardial segment relative to its baseline length, and it is expressed as a percentage. So if there is at the end diastole, L0 is the before the deformation, and L is the final length of the myocardial fiber at the end of the systole, then the strain percentage is given by L minus L0 upon L0. So when we look at that, if there is decrease in length of a myocardial fiber, such as occurring during muscle contraction, that would result in a negative strain. So the negative strain means there is muscle fiber contraction. Then when there is increase in length, when there is muscle relaxation, that results in that would result in a positive strain. That is, if the strain is positive, that means relaxation. Strain rate. Strain rate is the speed at which the deformation occurs and is expressed as per second. So when there is an initial myocardial fiber at length of 10 cm, for example, shortens to length of 8 cm over 2 seconds. So then the strain rate becomes 1 cm per second. Now in strain rate measurements pertaining to cardiac muscle fiber, there is once you plot that across a graph, one thing you measure is the ABC, that is the aortic valve closure time. Based on that, there are different strain parameters which we decide. One is the peak systolic strain. It is always measured before the aortic valve closure. Then there is an end systolic strain, which is measured at the aortic valve closure, and there is a post systolic strain which peaks after the aortic valve closure. There are different types of methods of measuring strain. One is Doppler derived deformation imaging. Then there is echocardiographic acoustic speckle tracking by 2D. Then there is also tagged MRI based strain imaging. When measuring strain by tissue Doppler imaging, it's an indirect computation of myocardial deformation. The velocity gradients across the myocardial tissue are measured. The viability and deformation of the myocardium is measured. The strain rate is given by the strain per unit of time. Then tissue Doppler imaging strain rate data could be integrated over time to determine the strain. The direction of the myocardial contractility needs to be aligned in parallel to with the direction of the ultrasound beam. So by tissue Doppler imaging, the strain becomes angle dependent. It is reliable only in the apical imaging plane, and it becomes unpredictable in longitudinal axis or short axis planes by echocardiography. The E velocity of the endocardium is normally higher than that of the epicardium. So in the tissue velocity, there is a tissue velocity gradient which is seen in the TDI, and in akinetic but viable or non-transmurally infarcted myocardium, the myocardial velocity gradient still persists. There is no velocity gradient in scarred or transmurally infarcted myocardium. Now when measuring strain by speckle tracking, it analyzes motion by tracking natural acoustic reflections of speckle artifacts. Then there is a post-processing computer algorithm which determines the strain. It is user-defined region of interest is placed on the myocardial wall, and within this region of interest, the image processing algorithm automatically subdivides the regions into small blocks of pixels, tracking stable patterns of speckles. Now in the subsequent frames are then automatically analyzed by searching for the new location of the speckle patterns which are earlier determined within each of the block. So after this processing, the computer algorithm gives the strain for each of the myocardial segments. Now, in the advantages of strain by speckle tracking is that there is a potential to track the speckle in any direction within a 2D image, which allows the calculation of the myocardial velocities, displacement, strain and strain rate in any given direction. And it has a multi-directional tracking ability, and it is angle independent, unlike the tissue Doppler imaging, which is angle dependent. It depends significantly on good image quality and proper image geometry. The factors which determines strain when we are doing it by speckle tracking is physiological factors like age, gender, loading conditions. Then there are technical factors like orientation of the imaging planes, quality of the grayscale images. The significant inter-vendor differences are present in terms of the normal values. So there is no universally accepted normal values for different myocardial deformation parameters. The main differences between tissue Doppler imaging and speckle is that a speckle depends highly on image quality. Then there is angle dependence which comes in Doppler tissue imaging. Then there is a vendor variability in speckle tracking, which are the main key differences, and there are other differences are listed as well. And the tissue Doppler imaging mainly can best analyze only longitudinal strain, whereas speckle tracking can give longitudinal, circumferential and radial strain also. Now, among all the strain parameters, longitudinal strain is the more reproducible than the radial and circumferential strain and the rotation. So, the global strain has much better reproducibility than a segmental strain. So, the average of all the segments when it's analyzed and the global strain, and one that can be replicated in further imaging. Negative longitudinal and circumferential strain are the longitudinal strain and circumferential strains are negative, whereas the radial strain is positive. So, the normal GLS is -16 to -18%, and there is an intervendor variability among that. And circumferential strain is greater than the longitudinal strain with average values in excess of -20%. The radial strain is positive. It's usually in the range of +40 to +60%. The peak systolic strain rate varies between -1 to -1.4 per second. Now, radial strain rate is around 3.1 to 4.1 per second. The apical rotation is normally much greater than the basal rotation, which is limited by the tethering effect of the outer layer of oblique fibers, the middle layer of circumferential fibers, and the inner layer of longitudinal and oblique fibers. So, the apical rotation also can also be studied with rotation. Now, in the left ventricular free wall, the subendocardial fibers mainly give rise to the longitudinal strain. The mid-myocardial and the subepicardial fibers mainly give rise to circumferential, radial and rotations. Most of the cardiac pathologies involve the subendocardial layers first. So, the longitudinal strain rate is usually the earliest to get compromised. Radial and circumferential strain remain preserved or may even be accentuated during the early stage to compensate for the loss of longitudinal function. As the disease becomes more extensive and more transmural, the radial and circumferential strain also get progressively impaired. Conditions that affect the heart from the outside, such as constrictive pericarditis, in such conditions, circumferential strain and rotation strain may get compromised earlier than the longitudinal strain. There are some caveats to global longitudinal strain. One is that it has main inter-vendor variability, and there is also among the vendors also there is inter-software variability. So, when you are assessing GLS serially in individual patients, it should be performed using the same vendor, the same equipment and the same software. Now, in healthy person, the peak GLS is around -20%. Now, lower the observation value below -20%, greater is the probability of abnormality. If regional tracking in more than 2 myocardial segments is suboptimal in a single view, then in such patients avoid doing GLS. Now, in strain rate analysis, you will get either bull's eye representation plot and also strain rate curves. Now, what are among the presentations, what can be used best? So, in the pattern recognition, the bull's eye plot gives specific patterns which help us to determine if it is fitting into a particular clinical condition. The subclinical dysfunction, wherein the LV function by normal 2D echo can remain normal, but there is a subclinical dysfunction which can be detected better by average GLS values. Then the regional variation of individual myocardial segments can best be determined by a strain curve shapes. So when determining GLS of the left ventricle, you first acquire views in three different views. One is the apical plaques, then you have acquired the apical 4 chamber, then the apical 2 chamber, and among this the region of interest is decided. Most of the recent echo machines have wherein the region of interest is determined by itself, and the region of interest based on which you just need to apply the algorithm and just decide if the region of interest that the machine has picked up is correct or if you need to do minor adjustments. And based on that, once that adjustment is made and you process it, it gives the image in a quad format for each view. So in that quad format, you can see the GLS of each myocardial segment, and each myocardial segment is color coded, and based on that color code, there is also a strain curve for each segment. And also there is a longitudinal map which is given. And after you finish getting GLS for all the three views, you will get a bullseye plot, which is routine like the 17 cardiac segments which we study. So that gives you idea about overall LV myocardium. And the bullseye plot is also color coded, wherein the more towards red color shows that the GLS is normal. When it moves more towards blue, that the GLS is reduced. Now we'll look at some of the diseases and how GLS is affected in such diseases. So in coronary artery disease, the longitudinal function is in most cases the best early marker of a LV dysfunction. It also shows regional dysfunction, and the extent of ischemic area and the difference between transmural and non-transmural scar can be determined by GLS in coronary artery disease. And in the figure you can see that the LAD area, there is a reduction in the GLS compared to the left LCX and the RC areas. Then there is post-systolic shortening. In post-systolic shortening, the segment of the myocardium continues to shorten after the aortic valve closure. It is often after a short relaxation, giving one or two peaks, a systolic and a post-systolic, or a single peak after the aortic valve closure. A small amount of post-systolic shortening may be present in up to 1/3 of normal segments, but it is not more than 3%. The post-systolic shortening compared to the peak systolic strain is not more than 3%. If it is more, then it is called pathologic strain. So a reduced systolic strain and a higher post-systolic strain in magnitude, as well as later peak post-systolic strain. And the longer persistence of the post-systolic shortening after an ischemic event was associated with severe coronary obstruction. So in this image, you can see where the gray curve is the normal curve of a myocardium, wherein you have a post-systolic, end systolic and a peak systolic strain around the same levels. And in an ischemic myocardium, there is also a peak positive strain, which you can see in the initial part immediately after the end diastole, where there is a positive strain which is not present in the normal myocardium. Followed by, you also have a post-systolic strain which is labeled by PSS, and also a peak systolic strain which is followed as peak systolic strain which is higher than the post-systolic strain. This is more typical of a infarcted myocardium. And in acute MI, there is systolic thinning. It decreases systolic deformation and also increases post-systolic thickening. So it is directly related to perfusion. And in acute total vessel occlusion, there is systolic deformation is totally ablated and replaced by systolic lengthening, which is also like a paradoxical strain where you will find a positive strain. And once there is reperfusion, it restores deformation to near normal, but some early systolic lengthening and also post-systolic thickening remains present in the early phases as a result of stunning of the myocardium. And longitudinal strain is significantly reduced in the infarcted segments proportional to the area of the infarcted region. In patients with subendocardial infarct, the longitudinal strain are attenuated, but there is preservation of the circumferential strain and the radial strain. When there is a transmural MI, the circumferential strain and the radial strain are also impaired. Now, the segmental radial strain cutoffs of 16% and circumferential strain cutoffs of more than 11% are used to differentiate between non-transmural and transmural infarction. In rotational mechanics are also impaired in terms of when there is an infarction. Now in patients with MI or ischemia reperfusion assessment, the subtle systolic changes in deformation or strain rate can be analyzed in regional segments to determine the level and degree of infarcted tissues or globally with GLS. The standard deviation of time to peak longitudinal strain, which is expressed in milliseconds across the 6 segments, can be used to analyze dyssynchrony or mechanical dispersion. It also may be useful measurements in dilated cardiomyopathy. As you can see in the diagram next to that, there is a regional variation of or mechanical dispersion in a normal subjects. When there is, after the aortic valve closure, the peak systolic strain almost coincide and there is not much difference when the peak systole is achieved in each myocardial segment. But when there is mechanical dispersion, there is wide variation of the peak among different myocardial segments, which indicates that there is a dyssynchrony. In radial strain, you can also look, radial strain is a positive strain. So in a non-infarcted region, the radial strain is positive, and when there is dyskinesia, the radial strain is negative. In patients with ischemic cardiomyopathy and viability can be assessed in patients with ischemic cardiomyopathy. The identifying viability and myocardial contractile reserve can be done through strain imaging. The radial peak strain cutoff value to assess viable myocardium is 17%. And longitudinal strain value of around minus 10% following a reperfusion therapy after MI is considered non-viable. So if it is minus 10 or less or more towards positive side, that is minus 10, minus 5 or 0, is considered more like a non-viable myocardium. So a mean longitudinal strain without scarring around minus 10 is considered viable, where and more towards positive, more like plus 0.6 or even up to about minus 5% in segments with transmural scarring is considered non-viable. So a strain cutoff value of minus 4.5% is used to differentiate viable versus non-viable myocardium. Now comparing LVEF with GLS, a global longitudinal strain is more reliable for assessing the systolic function in patients in normal patients as well as in patients with heart failure. Now in patients who are on cancer chemotherapy and related cardiac dysfunction, the GLS detects early subclinical myocardial dysfunction even before the LV ejection fraction drops. So a relative percentage reduction in the GLS by more than 15% from the baseline indicates subclinical LV dysfunction. So in patients who are on cancer chemotherapy, and if there is a drop of more than 10 points to LVF less than 53%, you directly label them as cancer therapeutics related cardiac dysfunction. But if that is not the case, even patients with preserved LV function, if there is a relative drop of GLS compared to baseline by more than 50%, then that indicates subclinical LV dysfunction. Strain imaging can also be used to assess dyssynchrony. In patients with LVBB, there is early septal radial thickening followed by delayed posterior and lateral wall thickening. So there is a time difference in peak anteroseptal to posterior wall strain by more than 130 milliseconds. And the EF responds to CRT. So in patients, it is seen that patients who have wall strain more than 130 milliseconds, they have good response to CRT. The spectral tracking by radial strain was also associated with good response to CRT. The longitudinal and circumferential strain appeared less sensitive in detecting important dyssynchrony. So you can see in this, in a normal subject which demonstrates synchronous peak in radial strain curves, whereas in patients with heart failure with left bundle branch block, there is an early anteroseptal peak strain followed by the late posterior wall peak strain. So radial strain can be used to also assess responders after a CRT also. Now in patients with Takotsubo cardiomyopathy, if you acquire strain imaging, you can see there is reduction in various LV strains that extend beyond any single coronary artery territory. And the peak systolic strain and strain rates are reduced in the apical and basal regions predominantly. On the right, you can see that there is a bullseye plot which represents the peak systolic strain of the various LV segments with a clear regional systolic dysfunction in the anterior and the lateral segments with global strain of around minus 15%. In patients with valvular heart disease, you can identify subclinical LV myocardial dysfunction. The impaired longitudinal strain is the first sign of a myocardial dysfunction in patients with valvular heart disease. multidirectional strain and strain rate impairment occurred with increasing severity and chronicity. The twist mechanics are relatively preserved in patients with AS, AR or MR, including peak systolic twist velocity and untwisting velocity. But longitudinal strain, circumferential strain and radial strain, which improve after surgical intervention in AS, but whereas in AR it initially declines in, there is initial decline in circumferential radial strain which improve over the course of next 3 to 6 months. One of the strain imaging can also be used to differentiate between athlete's heart and hypertrophic cardiomyopathy. Athlete's heart usually may have LV hypertrophy, but there is normal longitudinal and other types of strain, but hypertrophic cardiomyopathy has decreased longitudinal strain. Athlete's hearts also have increased LV end diastolic volume where it is decreased in terms of HCM, but it decreases after deconditioning in athlete's heart, but there is no change with deconditioning in HCM. There is increased LV twist and increased early LA strain rate in athlete's heart, but whereas in hypertrophic cardiomyopathy it is delayed LV untwisting and reduced LA strain rate. So if you perform GLS in these 3 conditions, athlete's heart will have a normal GLS, whereas in hypertensive heart disease there may be a global reduced GLS, whereas in hypertrophic cardiomyopathy there is severely decreased GLS based on the variant of the HCM. In amyloidosis, there is a higher EF to GLS ratio which is formed to differentiate cardiac amyloidosis from other pathologies with increased wall thickness such as hypertrophic cardiomyopathy. A relative apical sparing pattern of longitudinal strain should raise the clinical suspicion of cardiac amyloid in the differential diagnosis of LV hypertrophy. As you can see in this diagram, in cardiac amyloidosis there is spared apical GLS, whereas in apical HCM only the apex part is involved, and in septal MI the septal portion of the myocardial segments are involved. In patients with heart transplant and with rejection, the normal transplanted hearts there is usually an impaired apical twist mechanism, while the LVEF and other multidirectional strains remain relatively unaffected. Denervation in the early weeks after rejection results in reduced longitudinal strain. A cutoff of longitudinal strain of -11% could predict cellular rejection. Few words on RV strain. Now RV is hard to assess by ejection fractional volumes due to the different geometry of RV. The longitudinal strain of the RV free wall is well reproducible and sensitive. Now normal values of the RV free wall, the RV free wall longitudinal strain known as RVF WLS is -20 to -25%. Now global RV strain is less standardized. Now it can be used in early RV dysfunction in patients with pulmonary hypertension, RV infarction, congenital heart disease and cardiomyopathies. It is a good prognostic markers in PAH and heart failure. LA strain. Now LA size is not equivalent to LA function. The strain captures reservoir, conduit and booster pump function of LA. And in LA strain you can determine different phases where there is reservoir strain during LV systole, which is normally about 40 plus minus 10%, and conduit strain which is in early LV diastole, and contractile strain during late diastole and atrial systole. The reservoir LA strain normally is about 40%. The reduction to less than 23% is abnormal and predictor of an atrial cardiomyopathy and is associated with poor outcomes. LA strain also predicts atrial fibrillation, heart failure with ejection fraction and also diastolic dysfunction. And it is prognostic in valvular diseases like AS and MR. Thank you.